Professor and Head of Department of Pharmacy Practice, JSS College of Pharmacy, JSS Academy of Higher Education and Research, Mysuru. He is also heading Clinical Pharmacy Department at JSS Medical College Hospital, Mysuru. Sir has had graduated from JSS College of Pharmacy, Ooty in 1990, completed M.Pharm from the same institute in 1992. He was awarded Doctorate in Pharmaceutical Sciences in April 2006 by Rajiv Gandhi University of Health Sciences, Karnataka, Bangalore. He has also completed postgraduate diploma in clinical pharmacy from the Society of Hospital Pharmacists of Australia, South Australia in 1998. He has also won the award, Roche Products Fellowship Award 1998 for the best paper submitted to Board of Censors, the Society of Hospital Pharmacists of Australia. He was a recipient of several academic and professional awards, including Aushadha Ratna Award for his meritorious contributions and professional awards, including pharmacy education. Also, he was awarded with the late Srimati V.G. Ol Memorial Award 2005 and later late Shri Ishwaryan Hukkeri Award in 2010 for his research publications. Also, 8 of his research papers have won the Best Paper Award in the national and international conferences. He has authored a textbook titled Pharmacist's Invention on Medication Therapy, Impact on Healthcare Cost, published by Lambert Academy Publishing, Germany. He has successfully guided 80 postgraduate pharmacy practice and PharmD students. Also, he successfully guided 7 PhD students and currently guiding 6 PhD candidates. He has 114 research publications to his credit, both in international and national journals. He has acted as a resource person in 127 national and international conferences. He is a chairman of Board of Studies in Pharmacy Practice, JSS Academy of Higher Education and Research, Mysuru. He is a member of a Signal Review Panel and Core Training Panel of Pharmacovigilance Program of India. Now, Dr. M. Ramesh sir is going to deliver a guest lecture on the topic Detection, Reporting and Monitoring of Adverse Drug Reactions. Over to you, sir.
Thank you very much, Madam, for your kind introduction. Could you please enable me to share the slides?
Yes, sir. Please, sir.
Is my slides visible?
No, sir.
No, sir.
You have enabled me yet?
Yes, sir.
Is it visible now?
No, sir, it is not.
I don't know. From my side, I did it, but
So try now, sir. Once again, please click on the share screen and then try, sir.
yeah. Now
Yes, sir, it is visible now.
is the slide visible now?
Yes, sir. Yes, sir.
Okay. Thank you very much.
Thank you, sir.
Thank you, Doctor, for your kind introduction. At the outset, I take this opportunity to thank the organizers of this event, especially Dr. Sabeswar, Principal, and Dr. Jagdish Miti, is the AMC Coordinator, for giving me an opportunity to be associated with you all today virtually and present a talk on reporting and monitoring of adverse drug reactions. As you all may be aware, in clinical practice, the terms adverse drug event and adverse drug reaction are often used as synonymous. but they are not synonymous. The term adverse drug event basically refers to the reported information upon which the causality has not been established. Once the causality has been established, the adverse drug event will become an adverse drug reaction. In a simpler term, one can define the adverse drug reaction as unintended effect or unwanted effect arising from the use of a medicinal product. But however, WHO in its technical document published in the year 1972 defined the adverse drug reaction as the one which is noxious and unintended and which occurs at doses normally used in man for the prophylaxis, diagnosis, or therapy of disease or for the modification of physiological function. The important point to be noted in this definition is it says that doses normally used. It means that even if the patient is taking the medication at a normal therapeutic dose, still he or she is at greater risk of developing adverse drug reaction. Adverse drug reactions are of great concern worldwide for several reasons. Firstly, adverse drug reactions are one of the leading causes of morbidity and mortality. Several thousands of disabilities and deaths have been reported due to adverse drug reactions. Also, it was reported that adverse drug reactions are the 4th to 6th leading cause of death among the hospitalized patients. Moreover, although the estimates of incidence can vary with the study design or the type of population and the definition of ADR adopted, studies have reported that adverse drug reactions account for 5 to 10% of hospital admissions and up to 35% of hospitalized patients experience adverse drug reactions. That means approximately 1/3 of hospitalized patients will experience an ADR during the treatment, and also around 5 to 10 admissions out of every 100 admissions are due to the drugs. Of all this, 6.7% of adverse drug reactions are reported to be serious in nature, and deaths have been reported 1 in 1,000 medical inpatients. So when you say 1 in 1,000 medical inpatients, it is 0.1%. So this is the 0.1% is the incidence of the fatal reactions. It is in the medical inpatients, but if you take the overall, the incidence may range between 0.3 to 0.7%. In addition, adverse drug reactions result in unnecessary increase in the healthcare cost. Studies have reported that in US, approximately $115 billion are being spent every year to tackle or manage the adverse drug reactions. It is US alone, $150 billion. Then you can imagine how much of the money is being spent worldwide to tackle or manage the adverse drug reactions. As you all are aware, adverse drug reactions result in the human sufferings, and it also can lead to adversely affects the patient's quality of life, especially when a patient develops a moderate to the severe reactions or the serious reactions. Adverse drug reactions are common not only in the hospital settings, but also in the community settings. Studies reported that up to 40% of patients who are receiving the treatment in the community setting can develop the adverse drug reactions. A Blower et al. A study conducted in UK reported that NSAIDs use alone itself accounted for 65,000 emergency admissions every year and 2,000 deaths every year. Just imagine, it is only one class of drug, so many admissions, 65,000 emergency admissions and 2,000 deaths. It is from only one class of medications that is in one country. Just imagine how many different classes of drugs are being used worldwide and in different countries. So that means if you look at what is the number of the adverse drug reactions, that are occurring worldwide is unimaginable. So it is not only that, it is a human suffering, it results in even the mortality and morbidity. That is a very great concern to the humankind. Now, when you say that so many adverse reactions are occurring worldwide, now the question arises, are all these adverse reactions are being reported? But the answer is definitely no. It is only the 2 to 4% of adverse reactions are being reported. But when it comes to the serious ADs, the reporting rate is 10%. So that means somewhere between, you can say that 5 to 10% of adverse reactions are being reported. That means there is a gross underreporting. This kind of underreporting is not only common in our country, but also it is very common even in the well-developed Western countries as well. So this is the statistics comes from the Western countries. That means only up to 10% of the ADs being reported. So that means remaining 90% of ADs either unnoticed or it is not being reported for several reasons. Some of the reasons why the healthcare professionals do not report the adverse reactions is maybe a complacency. They think that only safe drugs get into the market, but that is not true. We should not think that whatever the drugs that is already available in the market that are very safe. No, we think that it is already a regulatory has scrutinized this molecule and they felt that it is very safe. That is why the drugs have come to the market. So they don't bother to monitor the patients for the adverse effects. So that is one major reason why do that. The second one is the ignorance. That is a lack of understanding of how and where and what to report. There's a majority of the healthcare professionals, they do not know that how to report and where to report. As of now, the PVPI is taking all its measures to create an awareness amongst the healthcare professionals across the country to improve the reporting rate. But despite with all these odd effects, still the reporting rate remains to be less than 10% itself. One of the major reasons why these ADs are not being reported widely is, you can say that lack of interest and the lack of time. If you ask the clinicians or any healthcare professionals why you are not reporting, in our experience, they say that I don't have time. And sometimes they don't give much importance to this aspect. They say that, yes, I know that these drugs can cause these reactions. So what is the benefit which you are going to get by reporting it? So likewise, there are several reasons why the healthcare professionals do not report the adverse reactions. That is why the underreporting remains to be one of the major issues worldwide. So as healthcare professionals, we need to understand that it is our obligations to report an area whenever we come across such event in the patients. We should never assume that someone else will report it. What happens is, when a team of healthcare professionals, they're visiting the patients, okay, and one may think that the other person would report this. But it is the way that even other person also thinks that he would be reporting or she would be reporting it. So ultimately, no one would be reporting it. So ultimately, though they know that the patient has developed the adverse reactions, but reporting is not being done, thinking that someone will do that. But we need to understand that it is our professional obligations. Whenever we come across an area, it should be immediately made a note of it, and it should be reported to the authority concerned. Now, the question is why we should report an ADR. Why is it important? It is very important to generate the signal. Signal basically refers to the reported information that is previously unknown or not well documented. That means it is a kind of a new reaction. Therefore, it helps us in identifying the possible new and unknown ADs and interactions. Secondly, it is important to redefine the incidence. We need to understand that we can redefine the incidence through detecting the increases in frequency of adverse reactions. When more number of reports are being reported, so the reports can be analyzed to identify is there an increase in the incidence of the reported event. For example, if we take, today we think that the aspirin-induced gastritis, we think that maybe the incidence of aspirin-induced gastritis may be at 10%, but it may not be true in reality, because still we remain remain the 10% because reports are not being made. Perhaps if more reports are coming in, the incidence may be higher. We would come to know that when you do the analysis, the incidence may be higher than 10% aspect, because now we continue to go with the 10% because the reports are not being made. Thirdly, it is also important to identify the risk factors and as well as the possible mechanisms underlying the adverse reactions. As we all know that once we understand what are the risk factors for the patient to develop an adverse reactions to a particular drug, it is always possible that we would be able to prevent or minimize such reactions in the clinical settings. So it is very important. Similarly, when we understand the possible mechanisms behind the possible mechanisms or the underlying cause behind this adverse event, we would be able to manage the adverse reactions in much better way than what it is being managed today. Fourthly, it is also important to estimate the benefit risk ratio. As we all know that as long as the benefit outweigh the risk, the molecule will continue to exist in the market. In case if the risk outweigh the benefit, then the molecule will be withdrawn from the market. For example, you all may be knowing that rosiglitazone, it is an anti-diabetic drug that was banned due to the risk of the heart attacks. So how do we know that? Because we know that it is only because of the reporting. Just imagine if this has not been reported, still this molecule would be in the market and the people would be taking this, and we don't know how many patients would have died because of an heart attack, this effect. Okay, so that means we are saving the lives by reporting the adverse reactions. Only when we know that how safe the molecules are, okay, and once the molecules, okay, the regulatory decide that the molecule is not safe, then obviously it will be withdrawn from the market so that the patients, the lives of the people be saved. Then finally, it is also important to improve the drug prescribing and the regulations. ADA reporting can improve the drug prescribing as it acts as an alerting mechanism to the healthcare professionals. It can basically alert the healthcare professionals, see this drug as this risk. So that means once the healthcare professionals are aware of what are the risks associated with the particular medications and in whom the risk is higher, they would take all precautions to prevent or minimize such risk in the patients. So that means patients can be treated very safely. For the very recent example, we can say that molnupiravir, there is an antiviral drug recommended for the use in the moderate to severe COVID patients. We know that ICMR did not recommend it for the inclusion in the COVID treatment protocol, owing to risks of teratogenicity and mutagenicity. Just imagine if this is not being reported, and if the people continue to take, the COVID patients continue to take this drug, then there would be a lot of the risks that would have been associated with the use of these medications. So these are some of the reasons why the reporting is very, very important. These are some of the reporting methods available worldwide. These are not the only methods. These are some of the important methods that are being adopted worldwide. Of all this, the spontaneous reporting system is most widely and commonly used across the world, for the simple reason that this method is very simple and it is very easy to use, and it is less time consuming and it is less expensive. So that means the advantages are more with this method of reporting, that is a spontaneous reporting system, when compared to the other systems. That's why even today worldwide, the spontaneous reporting system is a major source of safety information to the regulatory of any country. You all must be knowing that spontaneous reporting system means it is a voluntary reporting. In other words, it is called as voluntary reporting. Whenever the clinicians come across or notices an adverse effect in a patient, he would simply gather the information and then simply report it to the AMC center or to the PPPA or to the UMC, whatever it is. Okay, that is what the voluntary reporting is. And as I said, it is a widely used method, okay, due to its various advantages over the other methods. Now the question arises, how do I recognize the adverse reactions? You need to understand that if you want to recognize an ADR, always suspect a drug as a cause of symptoms. It is very, very important. Whenever a patient develops a new symptoms, we should always suspect, could it be due to drug? What happens in most of the cases in the clinical settings is the clinicians may think that from a disease point of view, not from the drug point of view. But it is very, very important that we need to consider from the drug point of view as well. Because you know that the detection of an ADR is very crucial in the management of any patients. As long as if you are not able to detect an adverse drug reaction, you know that patient will continue to suffer. And it is not only the patient will continue to suffer because of that adverse effects, but also it could lead to the treatment failure, and it could lead to the prolongation of hospital stay of the patient, and also it could lead to the unnecessary increase in the healthcare expenditures. And sometimes, who knows, the patient may die because of that ignored adverse drug reactions. If it is a moderate or very severe or serious reactions, patient may even die, or it may end up with some permanent damage. So that means it is very, very important to ensure that it is detected at the early stage itself. If you want to detect the adverse reactions at early stage, the only way is you need to always suspect a drug whenever the patient develops a new symptom. Now the question is, do I have to see every patient who takes the medications to see whether the patient has developed an ADR or not? Yes, we must be doing it. As healthcare professionals, it is our responsibilities, our obligations, our duty to check for ADR each and every patient, because anyone who takes the medicine is at risk of developing the adverse reactions. Because we know that no drug is safe. Any drug can cause any sort of reactions in any patient at any time. That means the differential diagnosis of a patient in case of a new symptom should include the possibility of an ADR. That is very, very important. Now, when we say that any patient can develop ADR, there's no doubt in it. But at the same time, some of the patients are at greater risk of developing an adverse reactions. Now, who are those patients who are at greater risk of developing an adverse reactions? One is the special population. We know that the children and elderly and pregnant and lactating women, we call them as a special population, they are at greater risk. We know that children, the renal system and their hepatic system is not well developed, because you know that all the drugs are handled by the renal system, either the renal system or the hepatic system. Either it is renally cleared or it is metabolized by the liver, and then it will be eliminated through the urine. So that means these are the two organs, okay, that handle the drugs in our body. So in young people, these systems are not well developed. They cannot handle the drugs, so that they are very prone to develop adverse reactions. Similarly, the elderly population. You know that elderly population, their hepatic and renal system would have compromised because of the age-related, because of the aging process. Whereas we know that as we grow, the bodily functions obviously will decline. Okay, so the bodily functions decline, the organs like the renal system and the hepatic system also decline, and hence in elderly people they also may not be able to handle the medications in a way the adult population handles. Therefore, they are also at greater risk of developing the adverse reactions. Similarly, the female gender. If you look at the published literatures, the available literature suggests that female gender are more prone to develop the adverse reactions for unknown reasons. Some of the literature suggests that it could be because of the less muscle mass, or it could be because of the hormonal changes. But some literature suggests that for unknown reason, but the females are very prone to develop adverse reactions when compared to male. Secondly, the patients who are receiving the polypharmacy, the multiple drugs, they are at risk of developing adverse reactions. It is obvious because, as I said earlier, every patient who takes a medication, even a single medication, is at risk. When a patient is at risk when taking a single medication, obviously when he takes multiple medications, his or her risk level of developing the adverse reaction is much, much higher. There's no doubt in it. So those patients who are receiving more the number of drugs, then the higher the risk. Similarly, those patients who have more than one medical problems, because we know that elderly people usually will have a multiple medical conditions. To treat the multiple medical conditions, obviously the multiple medications are being used. When you use the multiple medications, once again, their the risk level, the risk of developing adverse reactions in those patients will increase. It is not only because of an individual characteristics of the drug of the multiple drugs which the patient was taking. There are chances of drug-drug interactions. There may be chances of drug duplicate. There are chances of increase in the dose or maybe the overdose. So there are a variety of factors will contribute to this condition. Sometimes there may be a chances of the drug disease interaction. There are multiple factors that can lead these patients to exposes these patients to at a greater risk. Similarly, the patients who are receiving the potentially toxic drugs, or the inappropriate or the prolonged therapy, they are also at a greater risk. As we all know that, the patients, especially the cancer patients, when they're receiving the anti-cancer agents, we know that anti-cancer drugs are highly toxic. We know that it is highly toxic. That's why invariably the cancer patients, whenever they take the chemotherapy, they would end up with one or the other side effects. And nausea and vomiting is a very common side effects in almost every patient. And if you look at even the long-term side effects like, anemia and, the alopecia, okay, is also common in the patients who are receiving these medications for the longer period. So because the characteristics of the drug itself is such that it is highly toxic in nature, okay, like the drugs like chemotherapeutic agents. So patients who are receiving that kind of potentially toxic drugs for their treatment, they are at higher risk of developing the adverse reactions. And also the patients who have a history of allergy or the previous reactions to drugs. If the patient is known to be intolerant to the medications, okay, or maybe a certain drug or certain class of drugs, okay, or to certain chemicals, then obviously they are at greater risk of developing the adverse reactions to the similar kind of drugs or the similar class of drugs or the similar group of drugs. Okay, so these are some of the patients who are at most at greater risk of developing the adverse reactions. So that means the attention should be given much more to these kind of patients, like children, elderly population, pregnant and lactating women, and patients who are receiving the multiple drugs, and patients with multiple medical conditions, and the patients who are receiving some potentially toxic drugs. So all this, these are the factors which you need to consider, okay, and observe very keenly and very closely to see that whether these patients have developed any adverse reactions. Because we know that in clinical practice or clinical settings, it is highly impossible to follow each and every patient, okay, though they are at risk of developing an ADR, even if they receive a single drug, but it is not possible in the clinical settings. So at least we should be, closely monitoring these kind of patients to see that whether they have developed any adverse reactions. Now the question arises, what should raise my suspicion of an ADR? When should I suspect that, yes, this patient has developed an ADR? You need to suspect when a patient develops a new symptom. What do you mean the new symptom is? It is not that it is previously not known. What I mean, the new symptom means it is a symptom that was not present at the time of admission. Patient has some medical conditions. He visits the doctor, and the doctor takes complete history of the medical history and say that patient has the symptoms of X, Y, Z. But then after that, the patient starts the medications, and maybe third day or fourth day of medication, patient may develop another symptom that was not present at the time of admission. So that means it is a new symptoms. Then now you have to think that new symptoms may be because of the drug which the patient was taking. That means now to assess the new symptom, so the drug should be incorporated as one of them, in the differential diagnosis. That's what we need to suspect. Always a drug could be a cause of a new symptom. And this will be more common, especially, when soon after a new drug is started. New drug means, once again, I'm talking about newly added drug. New drug means it's not that a newly marketed drug. A new drug means the patient was not taking that medication currently, but after third day or fourth day or fifth day, or another drug was added to that drug. So when a new drug has been added to the existing therapy of the patient, okay, and if the patient develops a new symptom, then always you can suspect that that drug could have led to that newer symptoms that could be considered as an ADR. Similarly, the case with the increase in the dose of medications. Maybe a patient initially he may be receiving the 500 milligram BD, then later the dose was increased to 1 gram. As long as 500 milligram BD, when the patient was taking 500 milligram BD, there was no issues. When the dose was increased to 1 gram BD, maybe patient would have developed a new symptoms because of the increase in the dose. So that also you need to look at. And similarly, a symptom arises in a patient, especially in a high-risk patient, then you should always consider it could be an ADR, and you should have a suspicion of it. And then you have to do the further analysis whether really the drug has caused that reactions, or it is because of the disease process, or it could be because of the existing disease condition, or it could be a new disease process. So all this assessment need to be done later. But the moment you identify a new symptom in a patient, you should always suspect is that a drug could be a cause of that. Now the question is, okay, I suspect that the drug could have led to this new symptoms. Okay, now what I need to do is, what you have to do is you need to screen the medication order. That means the prescription need to be analyzed. The drug therapy need to be analyzed. What you need to do, we have to look for the appropriateness of drug use. How appropriately the drug is used in that patient. Because if the drugs are used inappropriately, there is higher chances of patient developing or experiencing the adverse reactions. Either maybe an overdose, or maybe using the unnecessary medications leading to the multiple therapy, leading to resulting in the drug interactions. Okay, or adding a new drug which was not required, and the drug is more of a highly toxic in nature. So things like that, you need to look at whether the patient is receiving a drug which is appropriate for the patient existing medical condition or not. That is one thing is. So if there is an inappropriate medications, then obviously you need to look into that, because the patient is at high risk of developing the adverse reactions. Second thing is you need to look at there is a sudden cessation of any medication. You just check whether any drug is stopped immediately or abruptly. That is very, very important. Because most of the time what happened is, if the clinician suspect that there is a new symptoms, and that could be an adverse reactions to any of the medication, then immediately he will stop administering that medications. Initially the drug has been given for example, antibiotics usually a 7 days therapy they will give for the 7 days. But suddenly 4th day the antibiotic was stopped. That means it should raise your suspicion. Why this drug, antibiotic, initially it was prescribed for 7 days, but it stopped on 4th day. What was the reason? Could it be because of the adverse reactions? Because most often what happened is the clinician suspect the patient has developed adverse reactions to a particular drug, you would immediately stop administering that drug. So that is where you need to look at it. Similarly, the abrupt dosage reduction. This dosage reduction is possible only for the type A reactions, not for the type B, because only type A reactions are the dose dependent, not the type B. Type B reactions are dose independent. Even if you administer a minute amount or a little quantity, even that also can trigger that, because these are hypersensitivity is of them. What is that? Immune mediated reactions, type B reactions are the bizarre reactions. But as a type A, it is pharmacologically mediated and is dose dependent. In such kind of things, the clinicians may reduce the dose rather than stopping the medications, especially if the clinicians think that this medication need to be given to the patient because of his medical condition, then obviously will continue the medications, maybe perhaps by reducing the dose. Likewise, you have to look at if there is an abrupt reduction in the dose, especially when it is a type A. So that there is a possibility that this patient would have developed a adverse. For example, insulin. We know that insulin-induced hypoglycemia. Insulin, the most common side effect associated with the insulin is hypoglycemia. So when the insulin is given, maybe at 20 units or whatever it is. So patient, if he goes to hypoglycemia, then suddenly they reduce the insulin unit from 20 to 8 or whatever it is. Okay, so that means there is a sudden a reduction in the dosage. Okay, that could be because of the side effects or the adverse reactions. So that is another reason you need to look at. Similarly, you need to look at, are there any orders that have been placed for some, the investigation, the some special test. They would have suddenly asked for some laboratory, investigations. Okay, that was not really required for the patient medical conditions. So that means the clinicians may have suspected the adverse degradations, and he want to confirm with the objective evidence. That's why he is seeking for some additional investigations. So that means if you observe that a patient has been asked to undergo some laboratory investigation, some test, okay, which is not really required for this patient medical conditions, or it is not done at routine pace, okay, then you should always be suspicious of that, and then you have to go with the further analysis. Similarly, you need to look at for the prescription of certain drugs, like especially the antihistamines and corticosteroids. If you find the medications like antihistamines and corticosteroids in any prescriptions, you should be more cautious and see whether these drugs are used to tackle the adverse degradations. Because corticosteroids and antihistamines are the drugs which are most commonly and widely used to tackle the most of the adverse degradations in the clinical settings. So these are also some of the symptomatic treatment, because there's a symptomatic treatment is being given to the patients who have developed an adverse degradations by using these medications. You need to assess. Of course, we understand that antihistamines and corticosteroids are also used for some medical conditions, but that is where you need to look at whether these corticosteroids or antihistamines are prescribed for the there is a need for the patients, as far as these medical conditions are concerned. That is where you need to look at. If there is no medical condition that requires the corticosteroids or the antihistamines, and if it is prescribed, then it should raise your suspicions, and then you go with the further analysis. So you need to look for these aspects while screening the medications. Then what you might see if the ADR has occurred in a patient, you might see either there are changes in the clinical measurements or changes in the laboratory measurements or the lab measurements. Okay, in clinical measurements, for example, there may be change in the BP, there may be change in the weight. There's a possibility that, okay, so BP has changed. Okay, during at the time of admission, the BP is normal. Okay, after 3 or 4 days of therapy, the BP of the patient would have gone down or it would have gone up. So then you have to suspect that, it could be because of the drug. Okay, so that's fair. For example, we know that opiates, when the patient takes the opiates, okay, that can decreases the BP. Similarly, carbamazepine, patient taking carbamazepine, okay, they can gain the weight. Okay, so like that, if a patient gains some weight, okay, over a period of time, and if he's taking carbamazepine, you should always suspect that it will be because of the carbamazepine. So like that, there may be changes in the clinical measurements. And similarly, there may be changes in the lab parameters as well, like including, maybe a liver function test, okay, or it could be, if you do the CBC, the complete blood count, whatever it is, that there may be changes in the values also. It is not only that, even with the other investigation as well, including the biopsies or chest X-rays and all those things, because we know that, okay, for example, chest X-rays will help us in identifying the pulmonary fibrosis induced with the pergolide. Okay, so that means you need to look at, are there any changes there in the lab parameters, or are there any changes in the clinical measurements? Okay. So now, some of the conditions, you need to understand some of the conditions like, the anaphylaxis, the Stevens-Johnson syndrome, and blood dyscrasis. It is always drug-related. Most often it is because of drugs rather than the disease process. It is very, very rare that patients will have these medical conditions like anaphylaxis, SJS, and blood dyscrasis as a disease process. But most often it is because of the drugs, because we know that there are several drugs that can cause us anaphylaxis, and there are drugs which can cause Stevens-Johnson syndrome. Most commonly widely used drugs which can cause the Stevens-Johnson syndrome and other blood dyscrasis. Okay, so that means whenever the patient has this medical condition, okay, and your suspicion should be always it is the drug related. Okay, but in the process of analyzing or assessment, you would end up with whether it is a drug related or it is a disease related, but in 90% of the time, it is because of the drug related rather than the disease process. So now the question arises, yes, I suspected that this patient had developed an adverse degradations to some of the medications, then what I need to do that? Obviously, you need to gather certain information, vital information, very important information to assess and find out whether the drug has caused the reactions or it is because of other reasons. So without that information, we would not be able to differentiate whether it is a drug induced or it is a disease induced. So you need certain information. So information can be gathered from different sources. Okay. You know that most of the data are available in the case notes and the patient medical records, and sometimes you may have to interact with the clinicians or the healthcare team or the nursing staff, whomever it is. Sometimes you may have to talk to the patient, get more information, depending upon what kind of information that is available in the medical records and what other information is required. And then you have to decide from whom I should get all this information, whether I should get it from clinicians or I'm getting it from nursing faculty or I should get it from the patient. And then you decide accordingly the information need to be gathered from these sources. That means there are multiple sources to gather the required information that is required for the assessment. Okay. So you can talk to the patients and get all those informations, whatever the additional information that is required. Similarly, you can also look at whether the patient is taking only one medications or multiple medications. And it is our patient is taking only the allopathic medications, or even he is taking, or he or she is taking the other system of medicines like the Ayurveda, Siddha, Unani, everything. You need to look at this. So that also need to be this. It is not that when patient is hospitalized, they would be giving some allopathic medications. You talk only about the allopathic medications. No, it is in the process of differential diagnosis. Okay, one should also consider when you say the drugs, you should also consider the Ayurvedic medications, Siddha and Unani or whatever it is. So all the other system of medicines, sometimes patient may be taking some other system of medicines, and it could be because of those other system of medicines rather than allopathic medications. So that is also very important. Then you also need to gather certain information about the timings. Timings, this is generally called as a temporal time relationship. We call it as a temporal time relationship. That means what is the time gap between the drug administration and the occurrence of the reaction? When did the patient take the medication and when did the reaction occur? Is there any plausible time relationship to suspect that yes, the drug has caused the reaction? For example, you say that paracetamol. We know that paracetamol available in the market and it can cause a fixed drug eruptions. Just imagine a condition where a patient has given taken the tablet paracetamol, and after 5 minutes he complains of the fixed drug eruptions. Now we have to look at, is there any possible time relationship? Now yes, patient has developed the fixed drug eruptions to paracetamol after taking the paracetamol, no doubt in it. But now the question arises whether can you develop this, whether this drug can elicit that reaction within 5 minutes when it is taken by the oral route. Because when a patient takes a tablet paracetamol, obviously you know that it will take at least 10 to 15 minutes of time to undergo disintegration, dissolution, and get absorbed into the receptor site to elicit its response. So that means within 5 minutes, if the patient complies of taking the paracetamol, if the patient complies of this any reactions, then it is unlikely that it is because of the drug. But at the same time, if the patient complies of this fixed drug eruptions, okay, within 5 minutes or within less than 5 minutes, once it is given by the injection, then obviously there are high chances, though the timing is less, okay, but he develops the reactions, okay, soon after the drug was administered. Because in intravenous route, especially the moment you place the medications in the veins, then no time it will get absorbed into the receptor site and it can elicit the response. So such type of timings also you need to look at it. Then have any clinical measurements of the lab results recently become abnormal? That is, when you are talking about adverse drug reactions, always our mind will go whether the patient has any signs and symptoms. We know that the lab investigation part will be either we forget to analyze or we ignore it. Okay, it is very, very important. Okay, it is not that you look at only for signs and symptoms in a patient, but also the laboratory investigation is also very, very important, because sometimes patient might have developed an hepatitis, but he would not have presented with the clinical symptoms. But if you look at these liver enzymes, the liver enzyme would have been elevated. So that means the drug could have led to the liver toxicity, resulting in the elevation of the liver enzymes, but he would not have the physical this. So that means it is always, you need to look at it. Similarly, renal failure. Renal failure is also the case. Patient may not develop a clinical symptom, well-known clinical symptoms, but if you look at the GFR, the GFR would have gone down. Okay, so that is very, very important. Even the laboratory in the data also need to be looked in to see that whether the patient has developed or the drug has caused any abnormal effects in the patient. Now, does the patient have any other medical problems? That is another medical. That means medical history also need to be gathered. Whether there is the past medical history or the past surgical history also very, very important. Okay, what are the comorbid condition which the patient has? Whether the patient has any comorbid conditions, if he has, how many comorbid conditions, what kind of comorbid conditions, are there any intercurrent disease, whether the patient is,
Sir, share.
Please continue, sir. You're audible, sir. Sir, can you hear me?
Ramesh sir. Ramesh sir. Am I audible, sir?
I have admitted, sir. We have admitted it. We are speaking.
Sir, you can unmute your audio now, sir.
ನೀವು ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿದ್ರಾ ಸರ್? ನೀವು ಅನ್ಮ್ಯೂಟ್ ಮಾಡಿದ್ರಾ?
Yeah.
So please continue, sir.
Yeah. Please allow me to share that.
Yes, sir. Yes, sir. It is. You are able to do it, sir.
No, but I'm not able to do.
I have not changed any settings, sir.
No, I think once again I have to do because I have rejoined, I suppose. I'm not able to share the screen.
Maybe as co-host, sir. Not participants. Are you able to share, sir?
No.
What comes, sir, when you click on share screen?
It doesn't show that share option. It says one participant can share at a time. Multiple participants can share simultaneously. Advanced
You
share.
click on the share screen link on that green button, sir, not on the arrow mark.
No, there only I'm clicking. Yeah. Now it is coming. Yeah. Can you see the slides now?
Yes, sir, it is visible, sir. Please continue.
Am I audible? Yeah, okay. So far you could hear, no problem?
No problem, sir, no problem.
Okay, thank you. Sorry for the disturbance. And now apart from that, another two more important information that need to be gathered is one is the de-challenge information, another one is the re-challenge information. The term de-challenge means it is the cessation of the suspected drug. That means you need to know what is the outcome of the de-challenge. That means what happened to the patient after we cessate the suspected drug. Whether the patient recovered from that reactions or the reaction continued to exist or the reaction is worsened further. If the patient has recovered from the reaction after cessating the suspected drug, then we call it as a positive de-challenge. If not, it is a negative de-challenge. And if it is a positive de-challenge, then the association between the drug and the reaction is much higher. If it is negative de-challenge, then association is the less likely. Similarly, the another important information is the re-challenge. You need to understand that re-challenge is possible only when there is a de-challenge. That means positive de-challenge. That means you should have cessated the suspected drug and the patient should recover from the reaction. Only then the re-challenge is possible. But we know that in clinical practice, the re-challenge is hardly done because of ethical considerations, because it is considered to be unethical to expose the patients once again to the similar drug, which has already caused some adverse reactions in the patients. But however, when it is medically indicated, medically warranted, okay, in cases like in tuberculosis patients, when patients have developed some kind of hepatotoxicity to the ATT drugs, then we need to go with the re-challenge only, because there is no other option. If you don't treat the patient, then patients may die out of the medical condition because of the tuberculosis. Patient need to be treated. So obviously you need to cessate all the drugs and then you may have to reintroduce. But there is a procedure for reintroduction, one by one they have to do. That is a different issue. But that means what I'm telling is usually in 99% of the cases, okay, re-challenge will not be done in clinical settings. Okay, but in where medically it is warranted, obviously one should be doing it. So, and it is at the discretion of the clinicians whether he has to re-challenge it or not. It is at the discretion of the clinicians only. So what you need to understand is re-challenge is possible only when there is a positive re-challenge. And when you're doing the re-challenge, you need to administer the medication in a similar manner, how the patient, in all aspects, that how the patient has taken received the medications prior to developing that particular reactions. That means if previously the dose was 500 milligram, you should use only the 500 milligram now when you are doing the re-challenge. If the route was oral, you should use only the oral. It is not the second time when you introduce the drug by other route, no. So that means the administration of drugs should be ditto in all aspects, whether in terms of the drug, in terms of the brand of the drug, or in terms of the dose, in terms of the route, everything should be strength, everything should be the ditto. Then you observe whether the patient develop the similar reaction, not the other reaction. Patient may develop another reaction. First time patient would have developed a headache, second time it is vomiting. Then it is not a positive re-challenge. If he develops the same reaction, that is a headache, which he had developed first time, okay, then you say that it is a positive re-challenge, otherwise it is a negative re-challenge. So positive re-challenge, obviously, that is more or like a confirmation where we say that the reaction is sign that the drug has caused that reactions, if it is there, and otherwise it is the probable, provided that the re-challenge is positive. Okay, so that is where you need to do this. These are some of the very vital, important information one you should gather the moment you suspect the adverse reactions in a patient. Okay, so these are the vital information that is required for the assessment. Only then the whole report will become valid. If these informations are missing, then the reported information is of no much use to take any decisions with respect to the alert or with respect to the regulatory decisions, whatever it is. Now the question comes, who can report? As you're all aware, all the healthcare professionals can report the adverse reactions. It can be reported by doctors, dentists, pharmacists, and nurses. And not only that to the healthcare professionals, but now the existing program, the National Pharmacovigilance Program of any country, if you take any country, that basically encourages the consumer, that is the patient, also to report. That's what in our own PV system, we have two different kinds of forms that I will come back later. That is, one is meant for the healthcare professionals and another one is meant exclusively for the consumer reporting. So even the patient or the consumer also can report to them, report the adverse reactions to them directly to the National Coordinating Center or to the any AMCs or into any other the hospital where they have this kind of reporting system. In addition, the pharmaceutical companies also will report. Pharmaceutical companies, the source for the pharmaceutical companies is the published literatures. We know that so most of the time we would come across the case reports, okay, published by the several researchers. So the pharmaceutical company will keep a watch on those case reports, and then if it is being reported to their product, then they would take this case report and gather all the information from that case reports, and where it is required, they also contact the author who has published that and get more details, and then they would report that into the CDSCO. They would also report, because it is important that even the pharmaceutical companies also follow their molecule for the safety, and then they have to report it to the regulators. Okay, especially for the newer drugs, they must be doing it. Okay, first 4 years they have to do them reporting. That's what we call it as a periodic safety update reports. The first 2 years they have to report every 6 months, and the next 2 years it is on annual basis. And then the regulatory will take a call whether, okay, depending upon the data that is submitted to the regulatory, they will take a call whether the companies need to further follow their molecule and report it to the safety information, or they can stop it at that point and whatever it is. So even the pharmaceutical companies also do that. And another source for the pharmaceutical companies also, they will liaise with the treating physicians, and then they gather the information of safety information of their product from the treating physicians, and that they will collate it, and then they may report it to the CDSO office. Okay, so These are some of them, stakeholders, they are involved in the reporting of an adverse drug reactions. And as I said earlier, and in our system in PVPA, the Pharmacovigilance Forum of India, it is what the system we follow is as worldwide. We also follow the spontaneous reporting system. Then obviously, whenever as an healthcare professionals, if we come across any ADR in any patients, then obviously we should ensure that it is being reported. Doesn't matter what type of report it is. Now the question arises, yes, now you know that healthcare professional, all of them can report it. The question arises, do I have to be completely certain what I have been seen as an ADR? Only then I should report it. Not necessarily. It is not necessary that you should be certain that yes, the drug has caused this reaction, only then you report. Not necessary, because what we are reporting worldwide is it is suspected adverse drug reactions. When we say that, the moment you say the adverse drug reactions, okay, by default, it means that it is a suspected adverse drug reactions. It is not the confirmed report. That means as a clinician, as a reporter, you no need to confirm that yes, this drug has caused this reaction before reporting. Not necessary, because what we are reporting is it is only the suspected adverse drug reactions. The moment we don't use the term, the suspected often, we just say adverse drug reactions. The adverse drug reactions reporting means it is always the suspected adverse drug reactions, SADR, but we don't use the word suspected often. Okay, by default, you need to understand that it is a suspected. So the moment you are suspicious, you should be reporting. No to be certain to report an ADR. But when you're reporting an ADR, you need to make sure that the sufficient or the adequate information is available. That is very, very important. I said, what are the data which you need to gather? You need to gather the information about, the medication and about the event, about the de-challenge information, re-challenge information, patient medical conditions, okay, patient details, okay. All this needs to be gathered. That is the minimum information it is required. Otherwise, it is going to be of no value, because one cannot assess the reported event if you don't have these informations. That's what I said. So when you're reporting it, you have to ensure that at least sufficient and adequate information is available, okay, so that the report will become valid. Okay. Now the question is, what should be the minimum information that should be available, okay, while reporting? Okay, what are the information that should be there? One is about the patient identity, patient details. What is a patient, the initials and patient gender, age, things like this, patient details. Similarly, the date of onset of reaction, when did the patient develop these reactions, then description of reaction. Most often what they do is clinician, they should simply, report only the nature of the event. For example, when patient has developed an headache, they simply report it as an headache. But what's important is it is a description of the reactions rather than the nature of quoting the nature of the reactions. For example, if it is an headache, you have to say that whether this headache is one-sided headache or two-sided headache, whether it is a dull aching pain or it is a severe intense pain, whether this headache is a continuous or it is an intermittent pain, or then whether the patient gets relief from headache when he takes the rest, or it is worsened when he is involved in some physical activities, things like that. A complete description should be given rather than simply reporting an headache, because that also would not serve much purpose. Okay, because we know what is the reaction, but however we do not know how the description. If we have the details of this, the complete description of the reaction, it would help us in assessing the likelihood relationship between the suspected drug and the reaction. That's what we call it as a causality. Okay. So that is very important. Similarly, the suspected medication details, that is also very important. You need to gather all this, the details pertaining to the suspected medication. When you say that medication details means complete information about the medication, suspected drug, like what is the name of the drug, brand, and what is the strength used, what is the formulation used, whether it is a tablet, capsule, or injection, or whatever it is, formulation used, and what is the frequency of administration, and what is the duration of therapy. Every details need to be gathered and should be available. Okay. Similarly, it is not only with respect to this, only the suspected medications, but also the other medication which the patient was taking at the time of experiencing the adverse reactions. Okay. It is not that patient may be taking 5 drugs or 6 drugs. Okay. Clinician may suspect only 1 drug. Okay. It is not that you gather the information about only the suspected drug. No, you have to gather the information about all other drugs which the patient was taking at the time of administration, at the time of experiencing the adverse reactions. Because if you want to attribute the reaction to the particular drug, then we have to rule out the possibility of the other drugs causing the same reactions. So that means we need to have the data. Without the data, we cannot rule out that, okay, these drugs are not involved in causing the reactions. When you don't have the data, how can you do that? So that is very, very important. Similarly, we need to have a details about the outcomes. What happened? Okay, what happened? Whether D challenge was done, whether D challenge was done. Okay, D challenge was done. What was the outcome? Whether D re-challenge was done. Okay, what was the outcome? So all these outcome details also should be there. Then reporter's identity. It is a very, very important, and most often we ignore that. It is a very, very important data, because the moment you report an ADR to an AMC center or to the PVPI or UMC, they would scrutinize the report and see that whether all the report informations are available or there is no contradiction in the available information. Because if some data is missing or there is some contradictory information is available in the reported then obviously they have to get back to the reporters to get a clarification. So that means it is very, very important that the reporter's identity is also mentioned. Okay, that is so that they can get back to the reporters if they need more informations or if they need any clarifications in the reported event. And the date of report when these are some of the basic information, minimum information that should be given while you are reporting in adverse reactions to any of the center. Then question comes, what should I report? You can ideally, if you you can just say that you can report any reactions. You can report any reactions. Okay, any reactions to newer drugs. If some new drugs are being marketed in the market, okay, and if the patient has developed any of the reactions, maybe as mild as nausea, or it could be as severe as Stevens-Johnson syndrome. Anything could be reported. That should be reported. Then newer reactions to any drugs in the market. Newer drug reactions to any drugs in the market, because the drug may be available in the market maybe for the centuries, but you come across a new reaction that was not reported till date. That also can be reported. I would say that almost 7 to 8 years back, okay, we have reported aspirin-induced sneezing. That was we observed a sneezing after taking the aspirin in our own student only. A student was taking aspirin and he developed sneezing, and we also did a re-challenge and all those things, and we reported that. During that time, we also contacted WHO database to see that whether this kind of reactions have been already reported or not. They said that they do not have, they have a very few reports about rhinitis, aspirin-induced rhinitis, but not the sneezing. Then we have reported, and in fact, we have published this as a case report. In one of the reputed journal. So that means, it doesn't mean that, okay, we think that aspirin is there in the market for the more than century, more than 100 years. Okay, and people, okay, have so many people have taken, okay, oh, it will not cause this. We cannot come, guess like that. Okay, the moment you observe, you have to gather all the information, do your own assessment, and then if you suspect that it could be because of this drug, then you should simply report it. Okay, that is very, very important, because we don't know what type of populations or what which individual will develop what type of reactions to the drugs. Okay, that's what I said. No drug is safe. Any drug can cause any reaction at any patient at any time. It doesn't mean that. Okay, so most of the time, what we think is, okay, paracetamol. I have taken a paracetamol along, many times. Okay, for some fever or headache or some body pain, whatever. I have taken multiple times. I did not develop anything. So that means doesn't mean that if you take a paracetamol next time, you will not develop any adverse reactions. You may develop any adverse reactions to this, because there are a lot of it is not only the inter-individual variability, but also there are a lot of intra-individual variability is also to be considered in that time. You may be tolerant, you might have been tolerant at that time, but not today. Okay, because of some intra-individual variability. So that means that is how you need to look at and do this. Otherwise, what happened is we will ignore. This is not because of this drug, because I have taken these drugs earlier, I didn't develop anything. Okay, so are my patients who have been taking these drugs earlier, so my patient did not develop this reaction, so it may not be due to the drug. We simply ignore it, but reality, it would have been because of the drug itself. So then similarly, the rare and uncommon adverse reactions also should be reported. Then severe reactions of any type. If the reaction is severe, then that should also be reported. Then serious reactions. there is a difference between severe. I said here severe reactions, and here you have a serious reaction. There is a difference between severe and serious reactions. According to ICH GCP guidelines, a serious reaction is the one which either result in death of the patient, or it is a near life-threatening situation, or any reactions that result in disabilities or the permanent harm, or congenital anomalies, or prolonged hospitalization. If any of the reactions cause any of these conditions, then you say it is a serious reaction as per the ICGCP guidelines. But otherwise, it is not a serious reaction. Now, what is the difference between serious and severe is basically, as severe is, it is the increase in the intensity. It is a severe, it is an increase in the intensity. For example, if you say an headache may be severe, but it is not life-threatening. It is not life-threatening, and it is not going to have much implications on the patients. Only it may be the intensity of the pain may be little more. That's what, that is a severe. But at the same time, when you say mild heart attack, you would have heard that mild heart attack, though it is mild, it is a life-threatening reaction. So it is a serious reaction. So that is the difference between the severity and the seriousness. You need to understand, there is a difference. Then reactions resulted in increased healthcare costs. Any reaction that warrant many investigations and treatment and all those things, that also need to be reported. Ideally, as I said, okay, in the beginning, that simply, closing your eyes, okay, don't bother what type of reaction, whether it is serious or severe or non-serious, whether it is common or uncommon, whether it is known reactions or unknown reactions, whatever it is, the moment you suspect an adverse reactions, a new symptom in a patient, you simply report it. That's what you can report, any reactions of any type to any drugs. That is what we need to think. That's it. Then now the question arises, okay, now you know what needs to be reported. Now the question arises, where should I report it? Reporting can be made to in different organizations. Okay, one is you can report it to the ADR monitoring centers. Now you know that the PVPI, the Pharmacovigilance Program of India, has identified 395 AMCs, 395 adverse reaction monitoring centers across the country. So you can report it to the nearby AMCs. Okay, if you have your own AMCs, then you can report it to your own hospital settings. And if you do not have that, then you can report it to the nearby AMCs. Other one is, okay, you can also report it to the local hospital-based centers. That means some hospitals that might not have recognized as a, that might not have been recognized as an AMC center, but at the same time, the hospital has their own reporting system. If that situation also there, you can report it, because they may in turn report it to the AMCs, and then from the AMCs, the report can go to the national coordinating centers. So third option is you can directly report it to the national coordinating center, especially, some of the consumers, all the most of the healthcare professionals, the reports are routed through the AMCs, but consumers reports not necessarily to the AMCs. They would directly send it to the national coordinating center as well. And then you can also report it to the WHO collaborating center, that the report through the Vigiflow, through a system called Vigiflow. And even the national coordinating center also, the AMC centers use, they all have given access to the Vigiflow, and they would report all the reported information to the national coordinating center by using the Vigiflow only. Then you can also report it to the manufacturers. Under what circumstances one would report to the manufacturer is, okay, in case of trial drugs, if you have come across an adverse drug event to a trial drugs, okay, a clinically sponsored trial drugs, then you should be reporting it to the manufacturers. And similarly, the non-marketed drugs, okay, non-marketed drugs and newly marketed drugs. If the drug is recently released in the market after the approval from the DCGI, then that also can be reported to the manufacturers. Okay, so manufacturer, and then manufacturer, as I said earlier, manufacturers of the pharmaceutical companies also would report to these event to the CDSU or to the PVPA. That's what does. But ideally, if you have your own centers, as an AMC center, you report it to your own AMCs. Otherwise, you can report it to the nearby AMCs, because they would further assess, okay, and before that is being communicated to the national coordinating center. Then how should I report? What are the different modes which I can use to report this? There are different modes that are available for reporting and adverse reactions. One is we can use the reporting form. or we can use the telephone, or you can use email. You can do the reporting through email as well, the SMS, mobile app, and the Vigiflow. The Vigiflow is that, as I said, it is a WHO online program. By using this Vigiflow, one can report this. But the Vigiflow access is only to the AMCs, but a consumer cannot report it through Vigiflow or any non-approved centers, the pharmacovigilance centers. That means if their centers are not identified as one of the AMCs, they cannot report through the Vigiflow. But all AMCs, okay, across the countries, they all have an access to Vigiflow, and the reports are being communicated to the National Coordinating Center by using the Vigiflow only. So as I said, that one of the major kind of the modes that are being used to report an ADR is by using the reporting form. And this is the latest version of the PVPI's ADR reporting form. Okay, now if you look at this form, okay, on the top, I don't know where it is clearly visible or not. On the top, it is said suspected adverse drug reaction reporting form. That's what I said. Suspected, whatever we report, it is a suspected. That's why by default it is understood that it is suspected, not the confirmed. Then that's what I said. The moment you suspect, you should report it. Okay, no need to confirm before you report it. Okay, so that's what he said. But in the way when we are generally in the clinical practice, when you're talking about ADR, you just simply say that ADR. The moment you say ADR, it is always a suspected ADR. So it has a different fields. Okay, different fields. That I said that what are the minimum information should be available. All these informations are captured here. Okay. In addition to that, they have certain assessment aspects also, like causality assessment, seriousness, severity. All these assessment parameters also involved in. Okay. But as a reporter, okay, clinicians can fill the basic information and send it to the AMC, and then AMC can further gather all those information that are required for the assessment, and they would further assess and then analyze the report, and then send the completed form to the National Coordinating Center by using the Vigiflow. That's what they do it. So there is another kind of form that is for the meant exclusively for the consumers or the patient. As I said, that patient also can report, or the consumer can also report. And this blue form, there are two different colors. One is the red, and another one is the blue. The red is meant for healthcare professionals, and the blue is meant for the consumers or the patients. And there is some difference in this. If you look at the consumer reported form, the information to be provided is very, very bare minimum. But whereas if you look at the other side, the healthcare professionals, there are a lot of information, because that also include the assessment aspects also. But here, the consumer reporting, it is only the basic details. What is the event, when the date of event, patient details, the age, sex, and that, and what is the medical condition, okay, and what is his address, what medication he took, something like that. Very basic details are there. But assessment part comes in the another one, the red form, where the healthcare professionals are supposed to use this form. Okay. So this is for the consumers. Then apart from that, the reporting form is available. Okay, apart from this, for the healthcare professionals and as well as for the consumers, they have a separate reporting form for the other conditions also. Now, for example, if you look at this, they have an ADR reporting form for the cause, a separate reporting form, and they have a separate reporting form for the drugs that are used in the COVID-19, the drugs which are used in the COVID-19. So that means it is not that the same form which you use for all this. If it is COVID-related medications, there is a different form is there. You have to fill that form and submit it. If it is a causa, there is a different form. And for the remaining other drugs, it is the same form what I have displayed earlier. So that needs to be made use of that. And these forms that are available in different vernacular languages, the reporting form is available in all different vernacular languages. I think around 10 or 11 languages. Okay, and in all the South Indian languages, like you have in Kannada, you have in Telugu, you have in Tamil and Malayalam, of course in Assamese, Gujarat, and Hindi, Urdu, something like that. There are 10 to 11, I think 10 or 11 different regional languages. These forms are made available, and one can use this even the vernacular language forms as well. Not necessarily they should always use the one with the English one. Okay, and these forms are available in their website, in the PVPA website, and it can be downloaded for the reporting, okay, either by the consumers or by the healthcare professionals or the AMC centers, whomever is wanted to report any ADR to the PVPI or to the AMC centers. Then apart from that, reporting forms, as I said, they have a PVPA mobile app. They have a mobile app. So that means one can report by using the mobile app. The consumer can report it directly using the mobile app that is available. And this is available in both in the Google Play Store, and one can easily download it and then report it through by using the mobile app as well. And they also have a toll-free number to report. The toll-free number, that is 1-800-180-3024. That is also there. And if you are using the toll-free, then the consumers or any reporter, if they're using this telephone number, toll-free number, then they're encouraged to do so only on the working days, okay, between 9 a.m. to 5:30 p.m. Because after hours, they will not be available in the office to take the call. Okay, so it can be made, the reporting can be made through the toll-free number between 9 a.m. and 5:30 p.m. on all working days. And another option for reporting is even the report can be made through the email. Okay, so these are the two email IDs which is given, the pvpa@ipcindia.net or pvpa@ipcindia@gmail.com. This is another option for the reporting. That means if there are multiple modes are available to report an adverse degree actions, and the reporter should decide which mode is more convenient for him to use, and he can adopt any one of these reporting mode. But you should not use the multiple modes. Use any one mode. If you are reporting through mobile app, then that's it. Okay, no need to report once again through using this toll-free number. Okay, so one option, okay, the convenient option based on the individual, whomever feel whatever it is convenient mode, they can use that mode for reporting and adverse reactions. Now the question arises as we are reporting these adverse reactions to the PVPI, okay, to the AMC centers, and PVPI takes PVPI and goes there. What happens to the reported the adverse reactions? So when healthcare professionals or the consumers or the patients, when they report their ADR into the AMC centers would basically analyze the report and see that whether all the necessary information are available or not. If it is available, they would do their own assessment for various parameters. And then they would fill the form, and then they communicate it to the National Coordinating Center by using the Vigiflow. In case there are no lack of information or contradictory information, okay, things like that, then they can get back to this healthcare professional, the reporter, maybe an healthcare professionals or the consumer or the patient, whomever it is, they will get back to. That means the communication between the healthcare professionals, patients, and the AMC center is a two-way. Okay, so the two-way. That means they can also report, and the center also can get back to healthcare professionals for any want of more information or clarification, whatever it is. Similarly, then the AMC center, as I said, once they do their own assessment, and then if they are happy with the data that is available, and it is good in all aspects, then they would communicate to the National Coordinating Center. And once again, between NCC and the AMC, it is once again the communication is bidirectional. When the report is reported to the NCC, they would also assess. In the NCC, they have multiple committees. They have a quality review panel, co-training panel, signal review panel. Okay, working group is there, steering committee is there. There are multiple committees. Okay, from low-level committee to the high-level committee are there. Then this data, whatever the data which the NCC receive from all the 395 AMCs, they would further assess and analyze. And once again, if they wish, if they need some information, if they need some clarification from the AMC, once again, they would get back to the respective AMC from where they have received the report, and then seek for the clarification or the additional information that they do this. That means, once again, it is a bidirectional, the communication between NCC and the AMCs. So once the NCC analyze the report, and if the quality review panel is happy with the quality of the data that is being reported for that particular event, then they will maintain the record with them, and also further communicate that information to the WHO, the International Drug Monitoring Program that is there in the Uppsala, that is Uppsala Monitoring Center. It is the International Drug Monitoring Program in Uppsala. They will communicate to them. So it goes to even the WHO database that we call it as a VG-base. The data sits in the VG-base. Okay, there to do this. And once again, the UMC also can get back to the NCC if they need any clarification or any additional information. They will communicate each other, NCC and the UMCs. Similarly, NCC, in addition to the WHO database, communicating to the WHO database, whatever the decision which has been taken by the signal review panel or the working group and the steering committee, that would, in fact, if they require a change, okay, any change in the regulatory decision is required, then they would communicate that to the CDSO headquarters. And then where the CDSO headquarters also there, they have their own technical committee, they have a drug technical committee, and the drug technical committee, once again, they would assess the data and then take a call. And then once again, it is a bi-directional. CDSO, NCC is a bi-directional communication, and the CDSO office needs any further information, they would contact NCC, National Coordination Center, for seeking the clarifications or more additional information or whatever it is. And then they will take the drug technical committee in the CDSO, take the decision whether what needs to be done with the available informations. Okay, that's what maybe, as I said that initially, one of the important reason why we should be reporting it is the reporting if we make, okay, when the multiple reports are get accumulated, and those data can be interpreted for the various analysis, and one such analysis about them, you say that it is the safety of the drug, and based on the safety of the drug, then the CDSO can take a final call on whether the drug has to be withdrawn from the market, or does it require any change in the labeling informations, okay, or things like that. Okay, so it aids in the regulatory decisions. So ultimately, the information that is communicated to NCC, okay, ultimately leads to what? To improve the patient safety. And how it is going to improve the patient safety is they in turn analyze and make the recommendation to the CDSO for the amending the prescribing informations, or maybe for the drug withdrawal, whatever it is. Once the steering committee of NCC approves that, then it goes to the CDSO as a recommendation. Then CDSO also asks us. They do not directly take, okay, it has come from NCC recommendation. No, the drug technical committee in the CDSO will further analyze. They will take their own decision whether it has to be banned or is that required for any prescribing information, something like that. Okay, one example I can say that one of the is hypokalemia. Okay, the piperacillin and tazobactam induced hypokalemia is added newly into the prescribing information. That is a product information leaflet after it has been recommended by the PVPA. Likewise, I'm giving that as one example. Likewise, there are several examples. There are several prescribing change in the prescribing information was made in the this. Okay, because they will further, CDSO will further communicate to the pharmaceutical companies, okay, the respective pharmaceutical companies, asking them to make the changes accordingly in their product information leaflet. Okay, that's what we've been done. Similarly, drug withdrawal, as you all know that it is only because of the the reporting of an adverse reactions, pharmacovigilance. Otherwise, you can say because of the pharmacovigilance only, we would be able to follow how safe the drugs that are available in the market is, and then we would be able to take an informed decision based on the reported information. We can take the informed decision how safe the molecule is, whether it is the molecule can continue to exist in the market, or it should be withdrawn from the market or not. So in such examples, we know that the regulatory authority have withdrawn several drugs from the market because of the safety reasons. Okay, and the recent one is, we can say that it is a rosiglitazone. Now, that all of us know that rosiglitazone, it is an anti-diabetic drug that was banned because of the risk associated with the risk of heart attacks. So things like that will happen. So apart from that, the PVPA, the Pharmacovigilance Forum of India, also create an awareness amongst the healthcare professionals and the consumers. Okay, they do publish their newsletter once in 4 months of that. So every year there are 3 issues will come, and that will carry all this information, the safety alert, safety information about this, if there are any banned drugs, all those will be there. So it is just a communication to the healthcare professionals and then consumers. So they are also aware that yes, so and so things that happen, and they can adopt in their clinical practice. Similarly, such information also made available in their website, in the PVPA website, and also often they do the press release and as well as the press briefing so that they can reach to the mass. Okay, that is very, very important. So this is how the safety informations are used. Now the question is, it has so much of questions, but now all these areas are avoidable. Can we prevent or minimize? Yes, certainly we can prevent or minimize the adverse reactions. There is no doubt. If you look at the published literature, it says 30 to 50% are preventable reactions. 30 to 50%. If some of the articles, if you look at it, says that even up to 70% of adverse reactions are preventable. Because as I said that one of the major cause for this may be an inappropriate drug use. Okay, it is all unnecessary. It is the patient developing any reactions because of an inappropriate medication use is preventable. Okay, if it is okay, even if the drug is required, okay, when a patient is taking the multiple medications, okay, if sometimes patient may develop because of the drug-drug interactions, okay, patient may develop an adverse effect because of the drug-drug interaction, that is also preventable. So likewise, there are so many reasons, okay, why these adverse degradations are preventable. Okay, so obvious interactions, sometimes as a contraindicated, patient would receive the medication that is contraindicated in these patients. For example, sometimes, clinicians, if a clinician doesn't take a proper history of the patient, okay, then he would end up with prescribing some medication that is contraindicated to the patients that will bring some adverse consequences in the patient. Okay, like prescribing a beta blocker to treat hypertension in asthmatic patients, because obviously we know that beta blocker can trigger that and resulting in the bronchospasm. Okay, similarly that inappropriate clinical conditions, drugs are being used for no reasons. Okay, as we know that in clinical settings, invariably every hospital, every clinicians, they use antibiotics to treat the viral infections. We know antibiotics do not have any role in it. Okay, so ultimately what we are simply prescribing antibiotics to the patients who is having some viral infection where he doesn't going to benefit out of this, but however we are exposing them to for that, it is not only increasing their healthcare costs, but also more importantly, we are exposing them to their safety. Okay, that is very, very important. So likewise, the many things are avoidable and preventable. There are several studies that have proven that, okay, majority of the reported adverse degradations are preventable in nature, or it could be minimized to a greater extent. And these are some of the ways which I already told you. These are some of the ways by which we can prevent or minimize the adverse effects. That is, by avoiding the unnecessary and inappropriate use of medications, administering the medications in a proper manner, okay, and getting the complete history of the patients before we prescribe the medications to the patients, okay, something like that. We have already discussed. So these are some of the ways, okay, and means of preventing or minimizing the adverse events one should be looking into. So coming to this, that management of ADS, we know that obviously the management is very, very important. Okay, it is very, very crucial, and then it is possible only when we detect. That's what I said. Detection of adverse degradation is very crucial in the management of adverse degradations. If you are not able to detect, then you will not be able to manage it. Okay, and it is very, very important. We should have a rapid action. Okay, maybe sometimes important, especially when the patient has developed a very severe and life-threatening reactions like anaphylaxis, Stevens-Johnson syndromes. The treatment cannot be neglected, or it cannot be delayed. The immediate treatment has to be given. Otherwise, we are going to lose the patient. So that is what is very, very important. So now, in the first step in the management of ADR is the withdrawal of the suspected drug. The moment the patient has developed an ADR, the first line of management is simply suspend the suspected drug. Because if it is because of that drug, then obviously once you stop administering the drug, the patient will simply recover from the reactions. That is one thing is that. Then similarly, the second option is, okay, it is reducing the dose. For that is possible, as I said, it is if the reaction is only if it is a type A reactions, or if it is a dose-dependent reaction, then there is a possibility that reducing the dose may help, but not in the type B reactions. Okay. Second, the other thing is, apart from that doing so, okay, we can also treat the patients for the adverse degradations. So treatment, as far as treatment is concerned, you have a symptomatic treatment and you have a specific treatment. Okay. So most often, as I said, in the beginning, when you are looking for the, whether the patient has developed any adverse degradations or not, I told you to, when we are reviewing the case notes, one of the point, corticosteroids and antihistamines, because most of the times, patients are being treated, adverse reactions are being treated symptomatically by using the corticosteroids and the antihistamines. So you can for example, patient have developed a pleuritis or rash, itching, or whatever it is, they simply prescribes the antihistamines to overcome such this. That means it is a symptomatic treatment they would give. Sometimes there is a specific treatment. Wherever there is a specific treatment, then clinicians would opt for the specific treatment. For example, if the patient has developed an anaphylactic reactions, okay, they would go with the administration of the antidote like an adrenaline. Okay, adrenaline. So that is where it depends what type of reaction which the patient has developed, and whether for that particular to tackle or manage that particular syndrome or symptom, whether we have any specific treatment. If there is availability of specific treatment, we go with that. Otherwise, the patients will be managed with the symptomatic treatment and as well as withdrawing the suspected medications. But in managing that, once again, we have to remember that, okay, we should have a very clear therapeutic objective in mind. That means we should not treat for a longer than necessary. Okay, of course, treatment is required to tackle the ADR, no doubt. But at the same time, just because you want to treat the ADR, you cannot use this drugs for longer time, because you know that no drug is safe, as I said. So it can cause some problem it can treat that condition, but this drug can cause some other problems. So that means don't use unnecessarily, even if you are using the drug to manage the ADS. That is very, very important. And all should remember, as an healthcare professional, all should remember that all the healthcare professionals have a responsibility to inform colleagues about clinically important adverse reactions that they detect, even if a well-recognized or causal link is uncertain. Immaterial, whether you have established the causality or not, at least, spread this information, okay, to them, the fellow colleagues, okay, so that they're also aware that this kind of this drug can cause this kind of safety issues. At least they will be very cautious in using that particular drug in their own patients, in their own clinical settings, so that the harm can be minimized or prevented. That is very important. So to conclude, I would say that adverse reactions are inevitable risk associated with the drug therapy. It is obvious, it is inevitable risk. Whenever we use, as I said, no drug is safe. Whenever you use a drug, then there is a risk of developing the adverse reactions. We know that drugs are like a double-edged sword. One hand, it cure the disease, and the other hand, it can harm the patients. So it is like a double-edged sword. Okay, so that means since no drug is safe, so that means adverse reactions are inevitable risk that is associated with the drug therapy. But what is important here is, since it is an inevitable risk, okay, what is important here is the prompt recognition of the potential ADRs in the early phase itself. Okay, and then so that we can make the necessary interventions, okay, in order to prevent the morbidity or mortality associated with that reactions, and then the unnecessary investigations and treatments also can be avoided, and also we can also avoid the unnecessary human sufferings and the healthcare cost. And this kind of the morbidity and prevention of morbidity and mortality, unnecessary investigations and treatment, human sufferings, healthcare costs, everything can be prevented and minimized only when you do it at the early stage. That's why the early detection of adverse degradation is very, very, very important. And if you want to detect at early stage, then what is more important is you should always be suspicious. You should always be suspicious. The moment the patient takes the medications, you should be suspicious that whether if the patient develop any symptoms, you should be suspicious of it could be a drug related. It doesn't matter over the period of time when you're doing the assessment, it may be drug related, it may not be drug related, but your first thing should be always, you need to be suspicious of that. That is how you would be able to, ensure the safety to the patients whom you are treating. So with this, I conclude my talk, and by once again thanking the organizers, especially the principal, and as well as Dr. Jagdish Miti for giving me an opportunity to share my knowledge on this pharmacovigilance with you. Thank you, Malta.
Thank you, sir, for the wonderful session. Now I request Principal Sir to have a word on this session.
Namaste, Ramesji.
Sir, namaste, sir.
So nice to meet you after a long time.
Yes, sir.
Though I have tried my best to at least have a to share the dais, have a privilege to share the dais today with you. But I think the day has to come.
Yes,
I pray that it should come very early, and it should come to our institution and to encourage and enrich the knowledge of our youngsters, including me. I also included in that knowledge session also. Thank you very much. I am my dear students, brothers and sisters, I memorize the day with you, sir, at Pharmacy College.
Okay.
Yes, yes. So you are so composed, so compact. That time I was remembering you very minimum. You speak and you always concentrate for your subjects and your skills. So that all I have been seen in the 98
Yes.
when I was with you, sir. In the short period, we are there in the place where you are working now.
Yes.
We have taken our safe, taken bath in the Pharmacy College building. And thank you very much for your knowledge session. And I think our definitely our youngsters, budding doctors, they have taken a lot of message. And it's not like that, sir. The languages changes, but I want to share with them that exactly the ADR and all the things that what have been there in your message, it's been there in the long before, sir. It has been documented in their own languages. It may be called in Sanskrit or whatever maybe. So now at least the WHO has come for money. The ministry has come forward. The language of internationally, everybody has to understand what exactly, and the documentation we are very poor, particularly in the sector of Ayurvedic formulations and the drug as ADRs. Now it is the youngsters with your inspiration and Dr. Miti and their team. So I think in another 5 years, when we are looking for integration, 2030 is the era of integration. We are entering to the integration era. Probably this sort of knowledge session and documentation is going to make us more acceptable in the international forum. These 2 words. Again, Dr. Rameshji, I thank you on behalf of organization, and that means Pharmacovigilance, behalf of the institution, that is from our JSS, management, and behalf of entire our PGs and internees. I profusely, profoundly, I thank you and submit our gratitude to you.
Thank you.
Thank you, Rameshji. Happy Makar Sankranti.
Thank you, sir. Wish you the same.
If I remember, I think saris belongs to the language is Tamil. I think so. I remember.
Yes, sir.
Yes, Pongal is the biggest festival for them. In spite of all things, since 10-15 minutes I'm waiting when the thank you slide is going to come. So that means to say I am just complimenting you, sir. You are so involved. You are so involved in every word. You are so involved actually to transfer the knowledge. Thank you. Thank you, Dr. Team Miti, sir. And sir, I want to share with you. Morning also I said, Dr. Miti, sir, has recognized as the best coordinator in India.
Okay, sir.
Under the Pharmacovigilance.
Great. Congratulations, Dr. Jagdish.
Yes.
Congratulations. Yeah.
Thank you.
Thank you, sir. Thank you very much.
Thank you, sir.
Thank you. Thank you very much for the opportunity. Yeah.
We will have an offline, sir, one with your team, sir.
Sure.
Second, I will invite you, sir.
Certainly. I'm also, very excited to come over there and be with your group there. Yes, certainly.
Thank you, sir.
Thank you very much.